every year, the surgery chief residents pick a day to give grand rounds. This is Erik DeSoucy's day to give grand rounds. He's got a fascinating story of his transition through internship, then to being the, what do you call it there?
A flight surgeon.
Flight surgeon for 3 years before coming back to do his complete residency over again. And Erik and I were talking, he said he was originally going to be an ER doc, but his experience here, I think his experience with surgery convinced him to be a surgeon, not his experience with emergency medicine convinced him not to be an emergency medicine doctor. I think that's the right.
Yeah, I'm not gonna bag on emergency medicine.
No. I think we're all looking forward to the story of his travels through this very significant decade for him and his family, who's sitting in the audience as well. So
Yep.
Turn it over to her. Thank you.
Thank you. I wanted to take this opportunity to share some of my experience as a flight surgeon and to really kind of dedicate this to some of our prelim interns who are going to be going off to do flight medicine soon. In a lot of ways, this really feels like this is coming 5 years too late. It's almost like what you did for summer break, but I'm telling it about 5.5 years after the fact. Some disclosures for you. There's always the traditional Air Force, military, DoD disclosure. These are my own thoughts, a lot of my own photos, but none of this is necessarily guaranteed by the military. In medicine, we use a ton of acronyms. We do the same thing in military as well. So wherever possible, I'll try and remember to go light on the acronyms and at least explain them. And I put that final line in there just to tell you that I understand that I'm implicitly biased in what I'm about to tell you, because I actually really enjoyed being a flight doc. So let's take you guys back to the beginning. On the left, June 2009, about 20 days out from graduating from med school. I'm ready to be a doctor. See, under there somewhere, I've got my pager, I've got my ID badge. At that time, I was still wearing a stethoscope. And I had a great time here. It seems like one of those bizarre things. How can you, having not wanted to be a surgeon, how can you enjoy a surgical internship and then eventually want to come back to be a surgeon? So I did my time, and when I got my orders, when I didn't match the emergency medicine, I got my orders. And they said that I was going to go down and be a flight doc for the 48th Rescue Squadron. And so we were going to be moving down to Tucson, and we were going to be working with PJs. And I said, okay, great. What's a PJ? It's short for Pararescue Jumper, or Parajumper. And I wanted to share a little bit about their career field so you get a better understanding of what I was doing as a flight doc. But there you can see within about an 18-month period, you go from being doctor to being the doc for a group of fine individuals. And this is, in fact, Tucson. It's not Afghanistan. They sometimes get confused. So U.S. Air Force Pararescue, this is a group of individuals. It's really the only Department of Defense military asset that is specifically trained, equipped, and positioned to perform personnel recovery throughout pretty much worldwide. They live by the motto, these things we do that others may live. And they take that to heart every single day, whether it's with their training, with their actual operations, their day-to-day activities. Their history hails to, it really goes back all the way to the end of World War II, but they really cut their teeth and came into their own during Vietnam, where they took on the moniker of the Jolly Greens. They would fly the HH-3, HH-53, which you can imagine these giant helicopters that at the time were painted green, camouflage, and they would swoop down from the sky to perform rescues. And they took this symbol of the green feet because when these gigantic rotor blades, the wash from them would actually lay down all the jungle brush and make it look like there had just been a giant green foot that had come from the sky. So this is the symbol of Pararescue. Their training is vast. So they, in addition to being fully trained paramedics, they get additional training in close quarters combat, field rescue, working in all varieties of aircraft. They're all accomplished parachutists, both static line and halo jumping. They are experts at maritime rescue, working in boats and around ships. And then also they are tasked a lot of times with humanitarian missions because they are also experts at close confined space extrication and rescue. So when I arrived on station at Davis-Monthan, I met with my commander for the first time, and he said, okay, we're deploying in December and we're going to take you with us. You're going to be our doc. And oh, by the way, you're also going to be the medical director for about 50 paramedics that are at that squadron. So we deployed to Camp Bastion in December of 2010. We were in the Helmand province, which is in southern Afghanistan. And there you can see this was my clinic, this portion of Alaska shelter. There's my exam table. You can see some of my rudimentary sort of diagnostics that I had there. I had a Pro Pack and a stethoscope and some other, basically a bundle full of medications that I could prescribe. But very dusty, very, at that time, fairly cold, but it was a great experience. We had two separate compounds. One was the rotary wing, which was our helicopters, where I did a few missions on those, but those were primarily just the pararescuemen. My main job intra-theater was flying around in this. This is an HC-130 Papa. We would do intra-theater patient transport. So if somebody at a base in southern Afghanistan needed to go up to Bagram in northern Afghanistan, they would give us a call. They would drop what's called the 9 line, which is basically some stats on, where the patient is, when we need to get them extricated by, and some basic information about that patient. And then we would be wheels up and we would go. Sometimes we would transload from other aircraft. Here you can see us taking a 2-year-old from a helicopter onto our aircraft. And a lot of times, as you see down here, we really just would get a truck that would back up to our aircraft. We would offload their patients and really hope that what we were receiving matched up with our 9 line. In some cases, we got more than we bargained for. We worked out of medical supply racks that were tied to the side of the aircraft to keep them from flying around. A little green box at the bottom is an oxygen producing. It takes liquid oxygen, turns it into gaseous oxygen for us to use. But I didn't do this alone. I had a team of pararescue men, so basically paramedics there working with me. I had a cadre of ICU nurses that were there to help me figure out how to set up drips and modify things. So overall, we did a total of about 270 missions, transported over 300 patients. About 26 of those were intubated, ventilated, critically injured patients. But it's a fantastic experience. A couple of fun pictures. So at one point, we had to do a patient transport in a Norwegian armored vehicle, and I just couldn't get enough of the fact that they put their AED right next to the box marked hand grenades. And on the right side, you can see me jocked up as if I'm going to jump out of an aircraft. I did not jump out of an aircraft during my time in the with the 48th Rescue. But they were basically showing me what it's like to have an extra 100 pounds of gear and get ready to jump out of an aircraft. Redeployment. Redeployment almost sounds like they're going to send you to another crummy location, but for us, that's actually a term that we use to say that we're coming home. A couple of things you'll never forget are the aircraft that brings you back home, your first beer when you're outside of General Order Number 1, and the embrace of your loved ones. In garrison, so when we're working on the actual military base, a lot of opportunities for training. A lot of iterations where we could go to the local boneyard where they have aircraft like this DC-10 that you could basically just cut the aircraft apart and practice extricating patients from the airplane. Got to do a few air shows, loved wearing the green suit. I actually was this close to wearing it today because it is that comfortable. The only thing more comfortable is green scrubs and a black North Face. After that, went to Tropony Air Base. This was about 2 years later. Here you can see I've kind of been upgraded as far as my clinic setup, but still fairly rudimentary. You can imagine around this time, about 2012, there was the attack on Benghazi. We had Ambassador Stevens and the 3 other individuals that were killed. And so we were basically responsible for providing pre-positioned rescue assets in the Mediterranean, North Africa. The idea behind this was that we're out there, we're searching for the culprits behind Benghazi, and we need to support them. Not a whole lot of mission action as far as compared to my previous deployment. Picked a few civilians off of naval ships, but more than anything, a lot of good training. And as you can see, we got to do some fun stuff like watching air refueling over the Mediterranean at sunset. So fantastic experience, and I put hashtags around that as a deployment. We did run into a supply shortage. Unfortunately, my family, they sent me some much needed supplies. So never underestimate just the power of a simple gift like this when somebody's deployed, even if it's something as silly as a set of plastic instruments. So moving on. My time in Afghanistan really kind of solidified that I wanted to come back, and I knew I wanted to be a trauma surgeon. So we packed up our Penske, and we basically said, okay, we're going to head back to Sacramento and start training again. One of the things that the Pararescue does, at least at 48th Rescue, as a sign of endearment, when you're about to head out the door and go somewhere else, they basically tackle you. They strap you to a spine board. They take off your shoes. They paint your feet green. And then they use you. They raise you up over their head. And they use you as a big rubber stamp on the wall. So I love that photo. All right, so what's a flight surgeon? Everybody, I think, you hear the term flight surgeon. Okay, you're doing operations in the air. You're doing lap choles in the back of a C-130. You're going to do an appendectomy in a C-5. What is a flight surgeon? These are not flight surgeons. These are folks that would be pre-positioned to be able to do surgery in the back of an aircraft, but they are not what are classically described as a flight surgeon. This is more akin to what I would do on a day-to-day basis within a clinic. And the flight surgeon, as you can see, Colonel Theodore Lister described, as really being the medical officer whose entire purpose is for the care and well-being of the flyer. So let's take you back to the origin of the flight surgeon. Obviously, Wright brothers, 1903, marvel of human engineering. But of course, the military quickly adapts most marvels of engineering to the purposes of war. World War I, the British came into their own as far as military aviation is concerned. The 90 to 8 to 2, those numbers represent of all the crashes, of all the fatalities, of all the incidents dealing with the military aircraft. They identified that 90% of them were due to human factors, whether that be errors in judgment or just a physical defect in the person themselves. Only 8% were due to mechanical issues, and only 2% were due to actual enemy activity. And again, when you look at the percentage that was due to the physical defects within the people themselves, the ones that we had selected to fly the aircraft, 60% of those casualties potentially could have been avoided. And within 2 years, the British, again, were hot on this topic. Within 2 years of instituting a physical screening program, they were actually able to reduce their casualties from human factors down to about 20%. And Colonel Lister, and here you can see him as a brigadier general, he adopted this. He saw what the British were doing. He said, we need to do the same thing in the U.S. And he adopted this care of the flyer unit. And the purpose of that was to set those medical screening standards and to integrate physicians into the flying squadrons so that they could be really there front and center with the flyers. He also established a research laboratory which was there just to really explore this new area of aviation, whether it be altitude, vibration. There's a lot of things that go into flight that were really just becoming known. So if you go to the U.S. Air Force website and you punch in flight surgeon, this is what comes up. And unfortunately, I fear that we are still perpetuating that misnomer that we are operating in the aircraft, because this is the picture that they choose to put on there. But you can see that still front and foremost is the care. We care for those who are flying. And here's the actual flight surgeon job description. So we are the pilots, air crews, and missile crews of the Air Force work under stresses and conditions that nobody else in the world experiences. And it's the job of the flight surgeon in the field to care for them. So here you can see, everything from noise, vibration, exposure to fuels, altitude, G-forces, you can't really recognize him in here, but this is actually Alex Lowe, who got a ride at 70,000 feet in a U-2. And the one on the far right is Greg Kirby doing his 9G profile. So you're taking care of really healthy people in an unhealthy environment is really what I always took away from flight medicine, is that more or less everybody is really healthy, but we're putting them in some pretty extreme circumstances. As far as the actual career task, if you want to break down our day-to-day and what the things that we were responsible for doing, first and foremost, determining fitness. So actually examining people and saying, you know, should you really be flying in an aircraft? So we examine the patients. We also provide the medical care and we treat the patients after they become flyers. We also have to regularly participate in flying missions. Now, the purpose of this one is because you have to go out there and it provides a little bit of camaraderie with your patients. And more than anything, it helps you experience what they're experiencing. It's hard to, you know, talk to a pilot talking about doing 9Gs when you yourself have not done it. Developing preventive medicine programs to keep our force healthy, and then managing and investigating accidents. So if an aircraft goes down, a lot of times we're the first responders to collect the evidence from the crash and make sure that's preserved so we can learn from those accidents so they don't happen again. And then finally, just to serve as a medical liaison to the flying squadrons, because the commander of that squadron is a line officer who may not have really any medical acumen, and you are his source of medical knowledge to figure out and to advise him on how to best take care of their own people, and also to let them know, you know, why is somebody not able to deploy because they're injured or down. A little bit about the Air Force demographics. Currently, we're just a little over 320,000 strong. You can see our officer enlisted breakdown, and really, it's a young population. Those are the mean ages of those involved. And just remember that mean doesn't include anyone really under the age of 18. And you know, as we get older, we don't stay in the military that long. There's very few people over the age of 50 and 60. Of those, about 20% are female. And the officer flyers, the pilots, the navigators, the air battle managers, those account for about 5% of the Air Force population. If you add on the enlisted flyers, the combat controllers, the PJs, the ground-based controllers, the air traffic controllers, that probably balloons to maybe 10 to 15%. And then who are we as the flight surgeons? We are roughly 500 strong. Probably should have an extra 100 there, but again, sometimes it's hard to recruit to this field. About a third of them are internship trained, and about 2/3 are residency trained. So how do you produce a flight surgeon? Where do we get flight surgeons from? This is the general track that you would take from med school on through to being a flight doc. Initially, you have to do med school, and there's really two routes for that within the military. There is the Health Professions Scholarship Program, which is what I took, where you do civilian medical school, and then that gets paid for by the Air Force, and then you pay back your time. And then there's also the Uniformed Services University of Health Sciences, or USUHS, where it's an actual military-run active duty location. After that, you go on to your internship. So you apply to a match similar to everybody else, except our match comes out a few months before, which is kind of nice. It comes out in December each year. And if you don't match to a residency, you go on to an internship. And you can do an internship in either a transitional year, internal medicine, or surgery. And from there, if you apply to residency and don't get picked up, or you just decide I want to be a flight doc or a GMO or a general medical officer, you go then to the Aerospace Medicine Primary Course, or AMP course. And this is, it used to be about 5.5 weeks. It's ballooned up to about 8 weeks. But the whole purpose of this is to teach us operational medicine, teach us about the standards, how we're supposed to be screening the patients. They also give you some practical aviation training, which was a lot of fun, where you're basically doing 2 weeks of private pilot's lessons to, so you at least know what pitch and yaw and roll are, so you don't sound like a dummy when you're talking to pilots. AMP 301 was a little bit of spin-up training just to kind of top you off and make it so you're deployable. Here at the bottom right, you can see that's one of our altitude chambers where they can take you up to however many thousands of feet, so you can experience hypoxia and see what it's like to have a rapid decompression. There is, as of late, within the last 5 years, there's been this new route called operational residency. The purpose of this is to pre-select people into different fields, so emergency medicine, internal medicine, family medicine, and their plan is to bring on a pediatric version of this, where you do residency within the military or at a civilian location, and then you go on, your first tour is with a flight, as a flight surgeon. The purpose of this is, of course, to bring more residency-trained flight surgeons into the field. They have about 55 people in that pipeline so far, so about roughly 10% of our flight surgeon cadre. So I started thinking about this, so we talk about the different types of internship and what would be ideal for a prelim intern going into a role that is really primary care. So of your options here, you have translational or transitional internship, where really between the electives and the primary care, ambulatory care rotations that they do, upwards of half to probably a little bit more than that of your time is spent in an ambulatory care setting. In medicine, per ACGME rules, you have to have about 1/3 of your training in an ambulatory care setting. And then there's surgery, where we are required to do a half day of clinic per week average. So that comes out to about 10% of your time, whether it be an internship or residency overall. So, you think about what are the things, and this is, of course, in a clinic where you're dealing primarily with surgery patients, and you're not dealing with, lumps and bumps and, people that have sprained their ankle or people with upper respiratory tract infections. Here's a breakdown of what at David Grant Medical Center, DGMC, what our transitional year looks like compared to a general surgery prelim year. So obviously, general surgery, very heavy on general surgical portions. Trauma, our time in the ED counts for about 4 blocks of any prelims rotations. Burns and ICU, where we get some critical care exposure, accounts for 2 blocks. But then transitional, you have a lot more of what we consider ambulatory care peds, some of the OB-GYN, family medicine clinic, and then depending on what they do, their electives. So on its face, I think people would say, well, why don't we just have everybody do a transitional year? That makes so much more sense for people who are going to be flight docs. I would argue that there are some benefits to a surgery prelim year, and you can see them here. So exposure to trauma, I think, is again biased because I want to be a trauma surgeon, but I think it's so important for a military surgeon in general. Knowing how to at least act in a code, how to triage patients, how to resuscitate patients, procedural things like lines, chest tubes, wound care is huge. Being able to suture and again being able to manage pain. Those are all really vital things that if you're going to a war zone, if you're going to be seeing patients that are injured from battle, those are all crucial. Then there's the other thing. So strenuous training. I don't think anybody in this room would argue that a transitional year, an internal medicine year, is any more strenuous than surgery. Our large patient volume, we don't cap. Teamwork, working with everybody from nurse practitioners to discharge planners. There's a whole slew of people we have to work with on a day-to-day basis to make the operation work, and it's no different in the military. Time management is key, and then flexibility, just being able to roll with the punches and do what you have to do. And again, the military medicine really is part and parcel to wartime medicine. So what portion of our Air Force PGY-1s go on to a flight surgeon or GMO tour? In the table on the left, you can see on the top is the PGY-1 only spots that the Air Force provides. So between 85 and 90 per year go into one of those roles. And then the military match from the last 2 years, you can see that of that 80 to 89 population, between 55 to 30, or sorry, but between 40 to 55 of those actually applied and said, okay, I want to do residency. And of the ones that either did not apply or did not get selected, you can see it's roughly about 65% of patients or of the prelim interns go on to either a GMO or flight medicine tour. And here you can see our numbers over the last 6 years with our match. And it's interesting to see because every year is a little bit different. Some years we just have banner years where everybody matches into a residency, and then we have years where only 1 or 2 will. If you look at it, anywhere between 20 to 90% of our prelim interns will go into a flight medicine role. And because of this, it was because of this 20 to 90% that we developed the flight medicine track. And so this was an idea that was started by Dr. Galante. He asked Bashir El-Khoury, who's a former flight doc. He was actually a prelim gen surg intern with me in '09. And he asked them to come and just give the folks that are going out to flight surgery, give them an idea of what it's like to be a flight doc, give them at least a little bit of a primer. And that kicked it off. And then when I came back in 2013, it just seemed like a no-brainer for me to take on this task. And from that one lecture that Bashir gave however many years ago, we've really expanded this. And it's become one of those things where we have multiple lectures from multiple subject matter experts, nearly all of them coming from the base up here to give their perspective on primary care, how to deal with some of these fields that we don't get a lot of exposure to during a surgical prelim year. Is it helping? So we have been kind of reaching back to those interns that have gone through the prelim program, and we've surveyed them, and we've gotten actually pretty good response rates from them for this 3-year period. And 100% of them across the board thought that it helped with their transition into flight medicine. 91% felt that it better prepared them for their initial qualification training. And you can see some of the things that they thought were most important. And the clarification of expectations, kind of demystifying the unknown, was really what set this program apart for our interns. So where have they gone? This is where it gets kind of fun, because we get to see a lot of familiar faces. There you can see the inventory within the continental United States of different air bases that you could be assigned to. So if you look at where our interns have gone over the last 6 years, we've really been everywhere. We've been coast to coast. We've gotten some fantastic spots. We've got some really highly sought after locations, not only within the U.S. but also across the world. We've had deployments to the Middle East. We've been to Australia, New Zealand, Japan, Guam, and I'm sure there's a few there that we can't put up there just because of security reasons. And again, this is only, I sent an email out to every prelim for the last 5 years. I got about 9 responses, so this is really only about 20% of where we've been total. And I asked them to tell me, what did you take away from your time here at UC Davis? So they learned how to work hard. They learned how to kind of live with a sleep deficit under stress, being on call 24/7. They learned to load the boat and be honest. I think a lot of us would be very proud to know that they took that away. They learned about decision-making competence, how to manage large volumes, 30, 40 patients on a list. When you get down to a base where you're only taking care of a handful of people, that feels a lot more manageable. The variety of skills that they learn. So some of these elective rotations, and particularly things like trauma and burns, are crucial for getting some of these skills that they wouldn't get otherwise. Fighter pilot personalities, being similar to surgeons, I think we can all kind of smirk at that. Very direct and to the point, so knowing how to deal with that kind of personality. Learning how to build relationships, working with multiple organizations, and then developing the organizational and workflow skills that are going to carry them throughout their career. All right, so where are they now? Captain Colby Updegraff, he was here from 2013 to 2014. Again, some of you will remember him. He was intern with me when I came back, stationed at Keesler. And the thing I'll always remember about Colby is that the very first day we're meeting with our new program director down at Travis Air Force Base, and he says, "Do we have to go in the OR? If we don't want to, do we have to operate?" And it's like that's Colby to a T. So his big passion was informatics, information, how to make systems better. He's actually became the first commander of what's called it was a new concept within the Air Force, which is base operational medical clinic, where he has the purpose is to make things more efficient and to streamline some of the things that we do on a day-to-day basis. He's gotten some fantastic education. He's done a fellowship at Boston Children's, master's at Harvard. And he just really appreciated what you as the UC Davis residents and attendings provided him as far as a welcoming and supportive place. Where they did provide them, I did put their call names up there. I didn't ask for any sort of clarification on why that call name was applied. So sometimes they're acronyms, sometimes I don't know. So, but those of you who remember Brent Forrest, fantastic guy to work with. He is stationed at both Moody and Whiteman Air Force bases. He's been deployed to Eastern Europe. He's been to Guam a couple times. I thought this was really cool. So first flight surgeon to fly in a B-2 bomber since 2010. What an honor. And now he's currently a PGY-1 general surgery at Missouri, Kansas City. And I liked what he said, grind hard through the year and just realize at the end, it's all about your perspective. There's always going to be greener looking grass elsewhere. But if you really just take a step back, look at it with a different pair of glasses, you'll realize that, you've got it pretty good. Captain Andrew Stinger Moss, 2014 to 2015, he was stationed in Turkey and Japan. I like the 5,000 hours on the call in Turkey. That's completely legit because sometimes you're the only flight doctor. So you are on call 24/7 for that time frame. He survived the attempted coup in Turkey, made it out alive. And he actually led this medical response to an F-15 ejection in Japan. And to the point where he was actually helping brief the Secretary of Defense about the status of that pilot. Treated a couple STEMI patients that walked in, again, something we don't necessarily deal with on a day-to-day basis, but he obviously handled it well. And his thing is just work on your surgical skills. These are skills that you can use throughout your life. But I liked also where he says that, when he got to Turkey, he said, "Oh, you're a general surgery resident. Okay, you're going to be the trauma surgeon." He's like, "No, I'm not that kind of surgeon." But because you'll go to some places where you might be the best trained in what you're in trauma skills. Captain Caleb Rick James, stationed at Whiteman Air Force Base, and his focus has really been on quality improvement. I love the way this guy thinks. He breaks down the regulations. He mentions understanding your AFIs and how to use them to your advantage. Those are Air Force instructions. Those are our rules. But he's really one of those guys that can break it down and make processes better. And that is evidenced by the fact that he was awarded the 2018 Flight Surgeon of the Year for Global Strike Command. And he's up, I think, this month for possibly Air Force Flight Surgeon of the Year. And he'll be reapplying to residency soon. Captain Jean-Gabriel Quignette, so this everybody remembers him from just a few years ago. He ended up going to Hurlburt Field, which is one of the Air Force's premier places for special operations. He's deployed twice to Afghanistan, over 50 combat flights, 150 hours. He's been CASEVACing patients left and right. And he is reapplying to residency this summer. At last check, I think he was going to be an ER doc. But really just he encourages our prelims to really get a breadth of knowledge, soak up everything you can from this experience. Make sure that our rotations are diversified. That's on me and Dr. Salcedo to kind of look at that and going forward and seeing what we can do to make these rotations diverse. But he really liked rotations like ENT, neuro. Those were really helpful to him. And then more than anything, just because you're a prelim doesn't mean you shouldn't take something or try and get as much as possible out of this year. Captain Alex Hang Low, stationed at Beale Air Force Base, first responder to a fatal mishap. Certainly a position none of us would ever want to be in or to be placed in, but he performed admirably. And he's been the sole medical provider. Like you're the doc. You are the one taking care of your people. I did like his tongue in cheek here. It is kind of the best worst time of your life. It really depends on your perspective going into it. But I thank him for being honest. You do get to do some really incredible things. These are some photos from him flying in the U-2. Again, 70,000 feet, and only a handful of people can ever say that they've done that. Captain Armand Al-Khanjari, he was stationed at Moody Air Force Base. He's deployed to Turkey. He's received an Air Medal, which is kind of a big deal because it just means you've flown a lot. You've done a lot of combat missions. And he's now currently an intern at Duke, going to be going. He's in Bethesda right now, but he's going to be going to Duke for urology. And he just glowing reviews of us at Travis and UC Davis. So a lot of our interns don't really come into this thinking that they want to do flight med. Every year that I meet with them, I get maybe one or two hands where I say, "Yep, this is what I want to do. I don't want to do residency right away." But he took a lot from this. He loved being part of a team, and he knows that that's important going forward. Captain Colby Gray, he actually went to where I was. He went to one of the rescue units in Davis-Monthan. He's deployed to both Afghanistan and Iraq. He's been their deployed PJ medical director. Again, he's signing off on all their paramedic research. He is training them on mass casualties and in-field trauma care. And here you can see he's actually gotten some action. He's going into anesthesia, but he's gotten some action in the field, working with and helping with some of these traumas that come through. He also had fairly humble clinic setup. I like the little slide that he sent. He sent me a smear of somebody that he diagnosed malaria on. So just some of the things that you wouldn't think about dealing with here. But really just get out and get as broad of an experience as you can. Get comfortable with trauma and burns, especially if you might work with a rescue squadron. Captain Greg Kirby, stationed at Lakenheath. So that is, I don't know if you understand the spectrum of bases, but there are some desirable bases, and there's really desirable bases. And this is an incredibly desirable base that he ended up going to. Numerous TDYs or temporary duties throughout Europe. He's completed his F-16 9G qual, and he got to fly in 16s, 15s. He sent me some fantastic photos. He was the squadron photographer on some of their joint missions, and he had some fantastic photos. He'll be applying for anesthesia. But he also kind of reinforced that trauma skills are important. He hasn't had to use them, but he knows that they're important. If you've never seen this before, so the centrifuge, they actually put you in a little tin can, they spin you around up to 9 Gs. So that's him at 9 Gs, and you can see he's actually a really handsome guy. The thing about being spun at 9 Gs is it kind of shows you what you're going to look like 40 years later. So, and I'd be remiss if I didn't show you mine. So that was me a couple of years ago. You can see 2012, and this is what I'm going to look like in 40 years. So I actually weighed about 1,600 pounds for those 15 seconds. So it's an incredible experience. And I sometimes like to relate it to turning it up to 50. If anybody knows that reference, it's not like the turning it up to 11 from Spinal Tap. It's actually from what Prince Humperdinck did. So it literally feels like it's sucking the life out of you. And if you don't fight it, you will black out. And then I'd be remiss if I didn't mention our very own Captain Matt Sandridge, who's a very unique individual in the sense that he is one of only 7 pilot physicians within the Air Force. He trained here from 2013 to 2014, and he went on to the pilot physician program. So they select flight docs to go through pilot training, and he is now a B-52 pilot, which is just an incredible thing. All right, so what can our prelim interns do to prepare? Okay, this is for you guys. So explore those opportunities to expand your skills. Take every single patient encounter, every interaction to say, how can I apply this in the future? And the easy thing is, patients on surgery wards get colds. I can't really even tell if I've ever looked in somebody's ears while I've been here, but this is an opportunity to expand those diagnostic skills while you're here, and to look to those other resources that we have, the other programs, the internal medicine, family medicine. We can learn a lot from these programs. Ask questions and develop your thought process, because before you know it, you're going to be the doc. You're gonna have that status within your unit. So it's very important to develop the way that you're going to approach patient care. Be the interns we wish we could have kept. So work hard. I can't speak enough to that point, because I guarantee that that's one of the reasons I'm here today. Maintain positive attitude. I saw my fair share of flight surgeons that you could just tell that they were miserable because the Air Force had gypped them out of their residency of choice. And if you carry that into a flight medicine tour, it really just kind of poisons you and it kind of poisons the people around you. So having a positive attitude, even if this wasn't what you were meant to do, again, this wasn't my plan, but I would not change it for anything. So what can we do to improve their experience here? Continuing to incorporate surgical electives. I know this gets strained each year as patient lists swell and we want to keep more and more of our patients to the general surgery side of things. I think it's important to incorporate those electives. Plastics has always been really highly regarded from our interns because that's where they learn to sew and how to treat wounds, and they really enjoy that rotation. Things like neurosurgery, again, they don't sound that fun to me, but they've been really good rotations for them. Urology, ENT. So we need to continue to incorporate those electives so that we're not just giving them the trauma ACS, surg-onc sort of experience. Incorporate flight medicine clinical experience into the DGMC rotations. This is something we've actually started doing this year, where our interns have the opportunity to go and just rotate at the flight surgeon level at Travis Air Force Base. So even though it's only a clinic day a week or so, it's a good experience for them. Continue the flight medicine tracks and the didactics, so that's also going to be important going forward. Fortunately, at least for the next year or so, Harris has agreed to kind of keep this program rolling. But if you guys can pick up another flight surgeon from the field, that'd be ideal. And then just invest the time to really support, train, encourage, and understand kind of what they're doing and where they're going. It shouldn't just be prelim intern and categorical intern. Treat them the same. In mostly closing, so our Air Force prelim interns, they really are doing a tremendous job. They support this residency. They take fantastic care of patients, and they are going to fill a vitally important role, whether it's as residents, whether it's as flight surgeons or GMOs. These are the people that are going to be taking care of our most highly trained assets within the Air Force and really enhancing our effectiveness and flexibility. All right, so I have to actually go on script right now because I might not make it through this. All right, I've trained at some really great facilities. I've gotten to learn from some fantastic attendings, and some of them aren't around anymore, and even some of the buildings are gone. But you've all influenced me as a surgeon and as a person. I can't imagine having trained at a better program. I want to thank my co-residents. Thank you for your dedication, your camaraderie on the wards. It's been a true pleasure getting to know you. You guys are so important to making this work. My family, where would I be without Stephanie, without her amazing children? My sister, my parents, grandparents, they've all supported me and encouraged me every step of the way, especially Stephanie. The photo on the left is us as newlyweds. And as you can see, over the course of 13 years, I have a few more gray hairs, and I've only gotten marginally better at taking selfies. During Mimi Kwong's grand rounds on burnout, I was compelled to send this message to Steph. Her response says it all. And I completely agree with her wearing the cape. I love you, and I'm so blessed to have you on this trail with me. Thank you. knew I wasn't going to make it.
Yeah. Eric gets a standing applause, I think, because all of us recognize the dedication and commitment and of what a decade means and how significant it is in our lives. And all of us have lived that part of it. And if you're fortunate enough, you feel like Eric does when you're coming to the end of it, that it's been truly special. So thanks for sharing that.
It has
with us,
been.
Eric.
Thank you.
Any questions? Yes.
Yeah, Eric, congratulations on your career. I mean, you haven't even hardly started your career. Your future career too. But surgery training has changed a lot. General surgery training has changed a lot in the military. And I was a resident who was at one military medical center. We put a uniform on every day. We learned military activities with surgery. Now, when we have integrated programs such as this, you describe one track where residents, after an internship, do flight medicine and come back, they have a military background. What about the ones that start from square one with no military background? They go to David Grant, they predominantly work here, other rotations. Are they getting the military spin and military medicine side of things like they should? Is there a pretty good balance now, or could you see improvements with that?
When I first started, they only did maybe one block as an intern down at David Grant, and now it's bloomed to 2 to 3 blocks. So I think we've improved that part. A lot of it is just learning the day-to-day of what it's like to work in a military medical treatment facility, and a big part of that is the EMR, getting used to the rank structure. So I think that we are striking a fairly happy balance here. I think that we probably could rotate down there more and maybe get a better experience, but the problem is we get such a fantastic experience up here, and I would hate to denigrate that. So I think that right where we are right now is appropriate, and I certainly felt that when I left here that I had at least a good understanding of what it means to work in the military system, and a lot of it you learn on the job. You learn a tremendous amount on the job. Even the AMP course that they send you to, it's a 5.5 weeks of death by PowerPoint. So the amount that you're actually going to take away from that is probably pretty small, but at least exposes you to it, and gives you some perspective so that you can learn while you're on the job.
Eric, thank you for being such an amazing chief.
Yeah, thank you.
I was just very surprised by seeing the definition of a flight surgeon
Yeah.
as including well-being.
Mm-hmm.
It's like a very giant responsibility for someone who's never even been deployed.
Right.
And he doesn't even want to have that job. And so I wondered what ways you address that when you were a flight surgeon on your deployment.
Yeah, one of the amazing things is that we have such a healthy population, but they do a lot of unhealthy things. Whether it's alcohol, smoking, tobacco use. With General Order 1, when you go out to the field, there's really nothing to do but smoke and work out. So unfortunately, a lot of people take up the habit. So that's always been something to improve, especially with operations that are running 24/7. Sleep hygiene and wellness from that standpoint has also been important. We've integrated programs to improve that for the flyers, because it's not exactly hot bunking, but one team signs off, the next one comes on, and you got to keep that going for an entire deployment of for us it was roughly 4 months. So there's a lot you can do for wellness, a lot of psychological problems within our population, because they're exposed to some of the worst. Burning vehicles, dead bodies. They get exposed to some terrible things, and unfortunately they all have this tough guy mentality that you need to kind of block that in and hold it. And I've seen that on more than one occasion that kind of breaks. So there's a lot you can do from the wellness standpoint.
Eric.
One of the things that taught in general surgery and actually in CT and in general is mentorship is really important.
Mm-hmm.
In your first job out of training, you want to find a place where there are going to be people that are watching your back and that are helping you negotiate the landmines you're going to encounter. So how is that done as a flight surgeon when you're in the middle of nowhere with no resources?
Yeah, fortunately, the nice thing is that the Air Force is pretty well connected as far as communications go. So even when I was deployed for the first time, I always had somebody I could reach back to and get that kind of mentorship. But a lot of it, you have to just keep your spidey senses up and really, be overly cautious with a lot of things that you're doing. In general, I never felt that I was kind of hung out there to hang. I always felt like I had somebody to call back to. And certainly on some of those deployments where you don't have access to specialty care, there is a nice program that is run through Brooks Army Medical Center, San Antonio Medical Center, that allows us to call back from anywhere in the world and say, I need to talk to dermatology, or I need to talk to somebody from ophthalmology. We have that capability, fortunately. So you have the ability to reach out and touch somebody if you need them.
I know the hour's late. I have to say that I continue to learn about the role of military medicine, and particularly with the UC Davis connection. And it's really especially unique and advantageous to both sides, if you will,
Yeah.
the military medicine side as well as to us in the academic medical center, and how we develop this. And Eric, I think they gave us a beautiful example of the rewards that can come from that affiliation. So thanks, Eric, and good luck to you.
Thank you very much.